So everybody, welcome tonight to the AANA Kaur Comprehensive Orthopedic Resident and Fellows Education Lecture Series. My name is Dr. Wiemie Dwoge. I'm the Regional Medical Director for Sports Medicine out of MedStar Health in Washington, D.C., and honored to host this program tonight. So I'd like to introduce our international faculty tonight. We're going to be talking about high tibial osteotomy, something near and dear to my heart, something that has really grown in my practice over the last several years. Thanks to both of these men here on this slide. Dr. Adrian Wilson, Professor Adrian Wilson, is based out of the UK. He has published over 30 peer-reviewed articles on this topic and is recognized as one of the world leaders in osteotomy and knee alignment. Professor Kristian Kley, one of the most brilliant surgeons I've ever worked with, also very prolific in the osteotomy space, worked with legendary Dr. Leuvenhofer out of Germany, and now has taken many of these principles to the next level. Truly a master surgeon. And so we're really excited to have them share in this international experience tonight. And I think it was no mistake that we brought these folks in from around the world, because this topic has seen a huge resurgence in the last decade in Europe and Asia, and it's just started to take a foothold in the United States. Interestingly, we were one of the founding fathers through Mark Coventry of osteotomy, but then it sort of got lost in the shuffle with knee replacement, and now we're seeing it come back again. So we're very excited about our agenda tonight. We're going to be talking about indications in history with Professor Wilson. Then Professor Kristian Kley will talk to you about analysis and planning. Then I will be talking about tips and tricks for success. And then finally, we'll wrap it up with a series of case discussions to kind of illustrate what really happens and how this really works. So with that.
Hello, my name is Adrian Wilson, and it's a great honor to be talking today about the history of osteotomy and I suppose my journey with this. It's a great privilege, and thank you so much to Wimmy for inviting me and Kristian to be part of this webinar. Those are my disclosures in terms of royalties. So osteotomy really is key, and hopefully that will be the message from the talk. We can take care of arthritis by unloading damaged areas of the knee. We can treat instability, and in fact the slope is going to dominate the field of osteotomy surgery moving forwards. We can help improve movement. We can use it as an adjunct to other procedures that we do. And it should be the first thing you think about, whether you're doing meniscus, whether you're doing cartilage, whether you're treating someone for ligament laxity. Alignment comes first. And actually in Europe, Australia, outside of the States, it's become extremely popular. There's often standing room only in the ICLs, and this really has become a very hot topic over the last 15 years. So I've been interested in innovation. I worked hard with the Arthrex team, helping to pioneer All Inside. Did the first All Inside PCL. That was actually me. Worked with Reinhold, who actually visited us, the owner of Arthrex, and I conceptualized this idea of using an internal brace with a ligament. Great ideas. And so that's what brought me to work with Kristian, who is very like-minded and not just good at osteotomy and surgery. He's actually a very athletic gentleman. Here he is trying out this makeshift table that we had to construct in one of the hospitals we were working. And Wimmy has been a good friend of mine through the Arthrex years. He's also someone interested in innovation and has really taken osteotomy to the next level in the States, become this incredibly high volume osteotomy surgeon. And we ran this course together in Washington, and I hope to do more and more with Wimmy moving forwards. So we work with lots of companies. We're now working with Nuclear. Wimmy and I, Wimmy's into lots of stuff. He's very good at judo, and we're still part of this internal brace study group who's about to meet in Glasgow, and we continue to work together on that. So my journey here, I'm quite young in 2006. My mentor at the time, Neil Thomas, past ESCA president, was a colleague, and he said, we have to go and see Ronald. Ronald is doing something very special. Neil was the godfather in the States for the traveling fellows. And he said that Ronald was just doing some spectacular stuff that we needed to find out about. So we started our courses. We then created these educational videos. Look at this in 2013, 130,000 views, 78 for the DFO video. These have been obviously updated now. And that won an award. And now I've come together with Kristian to do simple and complex osteotomy in central London, where we've set up a centre. And we continue to teach during the pandemic. I ran this online course. We have a fellowship program, and we've published a lot of papers in this field. We've been part of the ESCA Osteotomy Committee, helping to build out the ESCA consensus in osteotomy surgery. Lots of live surgery, and quite often we're asked to perform osteotomy surgery live. This is an interesting course in Pune, 1,500 in the audience and 10,000 online. And as I say, we have visiting consultants and trainees on a regular basis. And you're all welcome to come. This is one of the courses that we ran, invited 30 experts during the pandemic. It was just a way of bringing us together. Just showing that we've been very, very committed to teaching and education our whole careers. So we know that the total knee is a great operation. It's not the holy grail. And we know that we have partial knee replacement as an option. These are fantastic. And we do 300 totals or 100 partials and 200 totals a year. And we've got the videos of people walking early after both bilateral simultaneous partial knee replacements. Everyone everyone has these videos. This guy, he was only in his mid-50s. He'd had failed osteotomy surgery from someone else. He was about to lose his farm. And he sent this nice little video of him at 3 months doing well after his total knees. So we know people, even with revision surgery, can do well. But this is a very, very important paper. So this is 65,000 patients in the Lancet, which is a very important journal in terms of its impact. And what it showed was that age and failure were linked. In the under 55s, the revision rate was 35% within 7 years in these under 55 groups. 60 was where they started to see a massive rise in failure. And in the under 55s, the mean time to revision was 4 years. And that doesn't count for how happy are you with your knee replacement. 10% delighted, 70% happy, but 20% at least dissatisfied and unhappy with their total knee replacement. So we should always be thinking, particularly as people do more and more sports as they get older, of keeping our patients in the green using repair techniques, regenerative medicine, using osteotomy surgery before we think about any type of joint replacement, and keep people away from the salvage section of this graph for as long as possible. So let's talk a little bit about evolution. So myself and Neil wrote this paper in 2013. James Smith put it together for us. We divided osteotomy into historical, and that was pre-1940, the early modern years up to 2000, and the modern latter years 2000 to present. And we won actually the best paper award at the ESCA meeting in 2014 for this. And it's really interesting delving into the history and seeing that Hippocrates actually had his Hippocratic scanner where he used to straighten people out all that time ago. Here, J.R. Barton in the late 18th century does a closing wedge osteotomy for an arthrodesis or pseudoarthrosis of a knee in a sailor. Sounds pretty tough, no anesthesia, no asepsis, but clever work. Brett does this biological plating slope change back in the 1930s, which is not that different to what we're doing now. Obviously, it doesn't have the sophisticated fixation. The dome osteotomy came along, and it really was a question of try and make the leg look straight, put them in a plaster, wedge it if necessary, and the results were mixed as a result of this. This amazing gentleman, Sir William McEwen, who has a great book that we would urge you to get online. He actually was listed as dresser. He was pioneering aseptic techniques, and he reported on 1,800 osteotomy surgeries in his personal series in the late 19th century. So then we move into this next section, the modern early years up to 2000, and this French surgeon did the first lateral closing wedge, 22 cases, Mark Coventry at the Mayo Clinic, then popularized the step staple. And this was a breakthrough. It did give pain relief and people were more active, but poor early results, wide ranges of indications, high complication rate. So it sort of died a bit of a death. We moved then to the modern latter years, from 2000 to present time, and Giancarlo Pudu, an amazing surgeon based in Rome, worked with Reinhold on the first internal fixator, the Pudu plate, which we're all familiar with. Alex Staubli then came up with the concept of the Tomofix plate, working closely with Professor Leuvenhofer and Ronald. And this, together with really great concepts in actually assessing and planning our patients, which really came from Douoguih. This is a fantastic book, and it taught us about the Kaur and how to actually plan for deformity. So we went through this evolution to where we are today, and we joined forces, myself and Kristian, with Sachin and with the guys at Nuclip. That's Greg, the CEO, and his partner, who basically own the company, have set it up, and they've really embraced our concepts. Ronald, Matt Olivier, Sachin and Wimmy making up this scientific advisory group. They have engineers and other surgeons, and they really can take your ideas and move them forward. And that's why we've worked closely to create this family of plates for HTO surgery, DFO surgery, rotation surgery. We have something now for everything. Kristian and I are very proud of this. This is, I think, a very important new device that we introduced, well, not new now, a few years ago. It's our care retractor that we put onto the bone. We lock it into position in front of the neurovascular bundle, and in particular, the aberrant branch of the popliteal artery, which often sits deep to popliteus. We scrape the bone, palpate, lock this into position. We use the double window technique that we've described, and we cut the bone into the slot of the care retractor in a very safe fashion. So we're very proud of that. As one of the innovations that we've introduced. Another idea that we conceptualized, myself and Kristian, is the hinge screw, which has become popular. And this allows us to open up osteotomies to really, this is a cadaveric lab that we did, and we were messing around. We were amazed at how much we could open. This is based really on the hinge rod concept from Nuclip, and we use this now routine in osteotomy surgery to protect DFO and HTO surgery to protect the hinge. Here you can see a hinge screw patient. Kristian's with the patient day one, no crutches. We can see the patient standing comfortably. And in fact, the morning after surgery, this is no blocks, there's no fancy anesthesia here. This is just bone-on-bone apposition from the closing HTO. And another great example, Conrad, who's a brilliant osteotomy surgeon himself. Kristian actually flew out to Warsaw to Conrad's facility, used Conrad's team to correct his valgus knee. He was in pain. Luckily, he put 2 hinge screws in because Conrad fell down the stairs a few days after surgery, but all was well. And Conrad, you can see in the first few days, he got back to operating at 4 weeks and sent this very nice little selfie image of him doing what he really enjoys, which is snowboarding. A good example and a good testimonial. So does it last? Does osteotomy work? So here we see a very young Ronald with his mentor, René Mate. This is back in the early 2000s, and this was a 20-year follow-up. So everybody that attended this was 20 years from surgery, and they wrote this wonderful book, which we would recommend that you read. It's still very relevant today. So what about my series? So I got a fantastic amount of support from Reinhold, from Arthrex, £500,000, and I used that to generate my own team of research assistants. We followed 651 opening wedge HTOs. We did the standard scores, Coos and Oxford, and we looked at survivorship. And we had a very nice 10-year survivorship, 92%. And in our DFOs, which again, the largest series in the world, 89% 10-year survivorship in 90 DFOs at 10 years. Really nice data, and this is supported by other units. James did a PhD for me and looked specifically at return to physical activity after osteotomy surgery, and there are lots of papers out there. This is nice registry data from Australia showing how well the osteotomy patients did, particularly compared to uni new patients. And we then went on as a group to form a consensus group for ESCA, and we won the best ESCA consensus in Paris in 22. Really, it was Matt Olivier Rags and Matt Dawson that were driving this the most. It was done in the standard way, and now there are a series of papers that help you in terms of making your decisions in terms of age, when to do it, how to plan it, and so on. Very nice consensus papers to guide you. So what about some case examples? So let me show you first a patient of Kristian's, 38. He's varus, obviously really quite varus. The Michelitz line, the weight-bearing line completely missing. Pain with activities of daily life, no sports possible. So whenever you see a weight-bearing line completely missing, the chances are it's double level correction. Obviously, you do the deformity analysis. Here we see him. He's got a beautiful inclination now of the joint. He's now running 30 kilometers a week. He's 1 year out and a happy patient. And now another example is this 29-year-old very active gentleman who came to us, flew in from Portugal. He'd had osteotomy surgery as a teenager on both sides. He had 3 goes at the left and 2 goes at the right. So he had pain with activities of daily living, no sports possible. We did our deformity analysis, and we did both at the same time, actually, using a bone wedge and the type 2 nucleate plates that we helped to devise and design. You can see the before and after images of his legs, and you can see the result at 5 months back, active, and now doing pivoting sports and a very happy patient. This is an interesting example. 58, semi-professional athlete, is actually a banker. 5K time in his prime, 15 minutes, amazing. 5K time in 2021, 19 minutes, still good, but pain for days after he ran, starting to get night pain. He wanted to run. So again, we were surprised that this chap turned out to be single level osteotomy corrections, because he's really quite bowed, but that's what the deformity analysis told us. 9 months post-op, he's running 35 miles a week, biking, aiming for a 6-minute pace per mile, and sent us this lovely picture image of his first place in this competition in Florida for 5K. First in the over 50s, fourth overall, and it was a serious race with 250 runners. What about this? Terrible arthritis, extreme deformity bilaterally, but particularly on the right, missing with the micklets, a very flexible 63-year-old lady, still running. So the only reason she came to us was not because she's in pain, but because she literally has knees that knock together and she was struggling to do the activities that she enjoyed, but she has very little pain. So we planned this out. It was a double level correction. Look at the before, huge correction the femur, big correction the tibia, two closing wedges, both medial, both closing, smiling the day after surgery. Again, no fancy blocks. This is her morning after surgery, happy, taking full weight and taking a few steps with Kristian, and she's done very well. Slope is going to dominate, and it's probably how the US is going to really get into osteotomy because it makes such an enormous difference to ligament laxity. We've devised now PSI techniques and ways of making this more straightforward. This was a very, very difficult operation to pull off, but it's become easier and easier. So let me give you a case 24, active slim patient, had an ACL, initially good, then deteriorated, lots of instability, pain with walking, no sports possible. And if whenever you see this in your clinical setup, you can see someone doing their own anterior, drawing their own pivot shift. This is a very bad prognosticator in terms of outcome. These patients don't tend to do well. So we looked at him and we looked at the lateral long leg. We measured him with the double circle method up from the middle of the ankle through the circles 5 and 10 centimeters below the joint line. And there's the slope, it's 19 degrees, high slope. So here we are, we're palpating the ACL, which actually wasn't bad. And Kristian's developed this wonderful technique, supratubercle. So the tubercle remains on, the wires have gone in, there's 4 wires now heading towards the hinge. Kristian's gone in with a precision saw and is now milling and removing this wedge of bone. And now you can see that the saw cuts are there, milling out the bone, a proximal biplane, which is an essential part of the surgery. It's then closed and it's then fixed with a staple and a plate, and that's the final result. If we look at this gentleman, you'd think at 2 weeks he'd be in trouble, he'd be in pain. Actually, he found this easier to recover from than his original ACL surgery. His wounds are healed nicely. This is a fairly minimally invasive technique, and you can see he's moving quite comfortably. I want to show the movement. Yeah. This young girl who's falling off her horse here, it's a quick little video, but someone caught her falling off. She had a recurvatum injury. She had really quite significant recurvatum and a small reverse slope. So we thought, what about a minimally invasive slope change, a very small 1.5 centimeter lateral incision, a 3 centimeter medial incision. Through that, we were able to do an open wedge and increase the slope very slightly, fixing it again with a nuclear plate and screw. This is 8 weeks down the line, and she's walking very comfortably. And if we look at her, she's moving very nicely. She's a very clever girl. Actually, she's just finished, just about finishing her A levels, and now wants to do orthopedic surgery. This is interesting. So look at this girl, 17, pain since she was 12, crutches for 5 years, multiple opinions. Last one said see a psychiatrist, went to see Ronald. Look at the way she walks. She looks like she's got valgus, she's kneeing in. In fact, she's actually got a straight leg. And my head's in the way, I'm afraid, but the weight bearing line is right through the middle of her knee, but her foot is externally rotated. And again, the CT, sorry, it doesn't show, but she's got significant external rotation on the affected side. So what did we do? What did Ronald do? I should say, it's just such a great case. This is her at 3 months. Single level derotation osteotomy, a 45-minute surgery, and she's cured. This is a patient, Kristian, who's actually in the Guinness Book of Records for the world's toughest shins. He's a martial artist, and the way he's achieved that, I'll show you in a second in terms of how he won that award. He was a double level correction on the right. He came to Kristian at 6 months and showed his technique for what he's about to do on national TV. And he apologized to Kristian and said, look,
just
I felt so
your
good, Kristian. I re-broke my record.
Right?
I went on
You've
national
done your world
TV,
record,
and here I am breaking baseball
and you kicked
bats,
some baseball bats,
on the
yes,
most popular TV show
with a double level osteotomy.
So yeah, a good return to sport. So, just wrapping up now, the International Osteotomy Network is something you're all welcome to join. It's an MDT, it's mainly experts, but we do accept trainees. And every day there's an interesting case, and the individuals are posting questions, what would you do, and giving information to colleagues. If you're interested, my is going to be at the end, so please make context. So think about this. Every 10 seconds, a knee replacement is being performed. 1/3 of these are suitable for an osteotomy. 1/3 are suitable for a partial, and 1/3 should be having the total. So we ought to think about that. When I completed my training in 2005, I spoke to my mentor, Peter Myers, and to Leo Pincheski, both absolutely amazing surgeons who did everything, every aspect of knee surgery. What do you think is the most important, best operation that we can offer? And they both replied immediately, osteotomy, and that was back then. So where are we now? Well, we have better patient selection, better pre-op planning, better accuracy. We have these great fixation devices, and we can get our patients going quickly. As I mentioned earlier, we have a centre in London. Wimmy sends us regular fellows where we can show and demonstrate some of our techniques. And really, osteotomy has undergone a bit of an evolution. And if you were a pit stop guy in the 50s and you were the state-of-the-art chap who didn't bring the espressos to the driver but actually knocked off the wheels, you would be saying, well, there's no way 70 years from now they're going to be doing that in 2.3 seconds, something that takes us 15 minutes, but we can. And we've really transformed this procedure. So come and visit. There's my email. Thank you once again to Wimmy for inviting us to be part of this fantastic webinar, and wish you all the best with your osteotomy surgery. Thank you very much.
Thanks for having me. Thanks for putting this all together, Wimmy and everyone, Matt, everyone who's involved. My name is Kristian Kley. I'm an osteotomy surgeon, basically knee and hip surgeon, but have a special interest in osteotomy about the knee. Never wanted to become a surgeon, never had the intention to do so, always wanted to do carpentry. And didn't get my apprenticeship signed off. Nobody wanted to actually have me. And so I had to study medicine, and now I'm a bone carpenter. And that's why we go through osteotomy in a nutshell. So osteotomy, we start with analysis in my part here. I'm talking about the analysis and the planning anyhow, because when we talk about osteotomy surgery, it counts for lots of other surgeries, obviously, but here it is also important. Is the indication, then is analysis, planning, and then is execution. And execution probably is only 25%. So it's very important to run into analysis and planning to know what you want to do and equip yourself with a proper plan. Because if you don't plan, well, then you cannot execute the surgery. So the very first thing we need for the analysis is a long leg standing film, and that is has to be taken in the right orientation. So it needs to be an AP view. And how to find out whether it's AP? Well, you're quite often advised that you need to check for the position of the patella, but the kneecap is quite mobile. So sometimes, even though the kneecap points perfectly straight at you, it's just not the right orientation. And therefore, I personally look at the kneecap, but I equally look at the overlap of the head of the fibula that needs to be 1/3. And I want to see the condyles straight pointing at you and not curved like you can see here. So then when we analyze the limb alignment, then obviously we need to assess both the proximal and the distal part, meaning the femur and the tibia individually. And that is important because we may, if we generally assess the overall malalignment, we may see whether it's varus or valgus and find some information on hip, knee, ankle angle, but we will not detect the origin of deformity. So we need to look at the femur and we need to look at the tibia. And there now we need to define centers, axes, and lines. And it's the same for both of them. So very straightforward. You need to find the proximal and the distal joint center. Then you need to find axes, which is the mechanical axis, as we plan on mechanical axes here. And then it's tangents to the distal joint line of the femur and the proximal one of the tibia. to define the lines. So let's go through this. There's the femur. Obviously, finding the center of the proximal femur is easy, as the center of a sphere is easy to be found. But obviously, it's a circle. But on a 2D image, it's not a sphere; it's a circle. So from there on, we find the center. And for the distal center of the femur, to me, that's the roof of the notch. Then you take the mechanical axis of the femur, and that is nothing less but the connection of the proximal and distal joint center. And then, as we said, you draw a tangent onto the condyles, on the most distant point of the condyles, and that is the distal joint line of the femur. And then you draw an angle, and by definition, and thanks to Douoguih for the nomenclature here, that is the lateral distal femur angle. And that is formed in between the mechanical axis of the femur and the lateral aspect of the distal joint line of the femur. And that is the MLDFA. M just abbreviates that it's referring to the mechanical axis. So M stands for mechanical, and LDFA means lateral distal femoral angle. And now the same for the tibia. Here we have the tibia, proximal joint center in between the spines. Distal joint center for me is the talus. And then the mechanical axis, and at the tibia, the mechanical and anatomical axes are parallel. And then the joint line is the connection of the subcondylar sclerosis of the medial and lateral side. And then by definition, once again, it's the MPTA, the medial proximal tibia angle. And as there is no difference between anatomical and mechanical axis, you don't need to abbreviate that and put as a suffix in front of the MPTA. So there is no MMPTA, but as a matter of fact, it would be MMPTA, as that correctly shows that we're talking about the mechanical axis. So this is the nomenclature of the joint angles, and that actually this is the major contribution of Douoguih, principles of deformity correction, who brought up these angles. Well, the angles themselves have been described already by Mikulic, Johann Mikulic, 150 years ago. But the nomenclature and the abbreviation and the schematics behind it is obviously courtesy Douoguih. Once again, we look at the mechanical side of things, and it is of importance now to check whether we are looking at the femur or the tibia, because then only when you individually assess, you can differentiate whether you want to correct in the femur or the tibia, or it may be in both of them or in none of them, because the JLCA expresses the wear and tear within the joint as it is the joint line convergence angle. And that would be an intra-articular defect as opposed to an extra-articular or metaphyseal deformity. And therefore, you need to assess the joint line convergence angle as well. So now how do we do the planning? Well, looking at what Dugdale and Noyes taught us, we obviously have our long leg standing film. We draw our Mikulic line, which is the mechanical leg axis, weight-bearing line of the lower limb, and that goes from the proximal center of the femur to the distal center of the tibia. And that intersects somewhere at the level of the knee, and in this case, hardly making it to the knee. So then we draw a virtual Mikulic line, which actually is a secondary line that intersects the knee where we want the intersection point after our correction osteotomy. And then we draw another line intersecting directly at this point. And then we have an angle. And when we open the osteotomy with this angle, technically it should line up. And that is very precise. Sadly, what is not precise is that the intersection point and our hinge of the osteotomy, they are not the same. And therefore, there is a mechanical deviation in there, and there is a mathematical error. And now, Rolly Jacob back then taught his registrar, Mignazzi, to actually look into this a bit more precisely and go through planning steps that are mathematically more correct than the Dugdale-Noyes planning method, which is simple and straightforward, yet anyhow not very much correct. So the HTO planning goes like that. You draw, once again, a Mikulicz line that detects the deformity, whether you have a varus or valgus. So by this, you don't need the hip, knee, ankle angle again. So then you draw your virtual Mikulicz line, and up until here, it's all the same. And then you define your hinge point, because then everything circulates around the hinge. And then, if that is the case, well, why don't you become the hinge yourself? So you actually place yourself at the hinge point, and you look at the actual position of the talus, and then you change your direction of sight, meaning you rotate your neck to see from the actual position where you are right now and where you want to be after the surgery. And these two lines are resembled by line A and line B. And in between, you have an angle alpha, and that is the correction angle. And that is transposed to the medial cortex in this case now, as we do a medial open wedge osteotomy. And then on a calibrated X-ray, you can measure the wedge base height H, and that gives you the opening height of the osteotomy in metrics. And you've translated an angular value into metrics. So now for the DFO, it's somewhat the same. You have the Mikulicz line, you draw a virtual Mikulicz line, you define a hinge point of the osteotomy, and that changed over the years. And in particular, the shape of the osteotomy changed over the years because we came from those old-fashioned blade plates that are still paramount and gold standard when it comes to stability. But as a matter of fact, the cut that we performed back then was rather horizontal. And what we do right now in order to have an isosceles triangle and a perfect matchup of the cortices after the osteotomy to gain higher stability, well, to do this, we have an oblique osteotomy, and that needs to be planned. However, that's the only way to do it for angular stable plate fixators, and that needs to be a cutout for a closed wedge, as you can see here, that creates no offset, has full cortical support, and therefore creates higher stability. So that horizontal cut was abandoned. Now, how to find that? Once again, you just define your hinge point, which is on top of the contralateral condyle, and then you choose any starting point close to the center of this isosceles triangle. And then you know whether you have shot the inferior or the upper one by just seeing whether you're here or here, meaning way too high or way too low. And then you dial in your 2K wires, cut out the posterior 3/4, and the anterior quarter is for a biplane osteotomy. But that's just a technical aspect and obviously nothing that you need to know for planning. Mikulicz line, once again, virtual Mikulicz line, find your hinge point, and then we do somewhat the same thing that we've done for the tibia. You place yourself over the hinge. And once you look at the hinge, once again, you can just dial in the correction and you draw your angle from here to there, from the center of the femoral head, where it is right now, to where it should be after the correction. And you can do this now by just creating a goniometer around this circular action and just rotate it. There's a very mathematical thing here right now with a planning software, and you don't need a software like this, obviously. But then you can dial in really precisely onto the degree what kind of angular correction you want to have. And when you've done this, once again, you come up with line A and line B, and you have an angle, and that is transposed to the medial cortex, and then you have the wedge base height. And in the past, we had to do it like this. Obviously, there's me 150 years ago in the times of Mikulicz himself, and that works for a single level. But when the deformity is gross, meaning the Mikulicz line doesn't touch the knee anymore, well, then mostly, as a rule of thumb, is a bilateral or double level osteotomy. And this double level osteotomy cannot be planned in a single go on a plain sheet of paper. So you need to just first identify, and that is what analysis and planning is all about. You need to identify the problem that here You cannot do this in a single level osteotomy without changing anatomy to an extent that possibly makes it all worse than the initial malalignment. So that's why you have to distribute the sheer amount of osteotomy height to 2 levels. So you offload the overall correction at 1 level, starting at the femur, because it's a definitive closing wedge osteotomy, leaving you with, let's say, half the amount of malalignment. And then you have to redo the whole planning. So it's actually 2 plannings in one. Other you will not find out. And luckily today, there is modern sophisticated software that guides us through this process, and we can see by just throwing in some marks at the corresponding anatomical points and landmarks that you can see here. So we can throw in some marks, and with those marks, actually, we can redefine everything, and then the measurement gives us all the values we need to have the MPTA and the MLDFA. And looking at this, now we can throw in some osteotomies. That's what we are doing here. And we can simulate now what happens when we osteotomize. And as a matter of fact, we have a varus deformity here. And this varus deformity can be valgized and corrected just at the tibial level. And let's do that now. You see all the values here, MLDFA 91, MPTA 82. And now let's correct it and bring the Mikulicz line just somewhere to the center. And you see that we have overcome from 82 to the 90 and overcome this. And actually now we are more than 90 and we've corrected it adversely to the other side round. And ending up with almost 100 degrees of postoperative MPTA. And therefore we create a slope that we don't want to see. And I think, well, that doesn't really make sense. So we go back to the drawing board. And as we said, we just offload the first half at the femoral side, correcting the femur from red figures to green figures. And that's perfectly fine. We've offloaded half of the malalignment. And then we just take the rest of the malalignment for the tibia. And that's how it works. And now you see both figures are green. So we've corrected everything. The knee is, the leg is straight. And no one's compromised any of these figures. But it obviously takes a bit more effort, is a double level osteotomy. So that's how we roll it. And thank you for listening.
Thank you, Professor Wilson and Professor Kley, for 2 really insightful, incredible lectures. I think it's really going to be helpful for our residents and fellows listening in. And now that we've talked about sort of the history and the outcomes in modern day HTO surgery, as well as a pretty comprehensive look at analysis and planning, I want to talk about some tips and tricks in terms of HTO. So I'm going to share my screen. Is this coming up? Let's do this.
Not yet, sir. Now it's coming up.
So how do I get the slideshow?
Perfect.
I remember when yeah, good. Is that good?
Yes, sir.
Can we minimize this picture of myself? Is that showing up on the?
No, it won't show up on the screen, but you can change it however you want to.
Okay. So I remember when I finished my fellowship at Curl and Job Clinic, now Cedars in California, osteotomy wasn't really something that was being talked about. It was sort of a fringe thing, something that you might have done as an adjuvant to make sure that cartilage restoration surgery worked, but it really wasn't something that we were using definitively for osteoarthritis in an older aging athlete to keep them out on the court or on the field doing what they do. But we're seeing a massive interest, a surge in interest over the last decade or so. And I can tell you the first time that I did an osteotomy in my practice, it was in someone who had terrible arthritis that I had recommended a total knee for. And she had she had refused a total knee. And I thought, well, maybe we could try the osteotomy. We did the osteotomy, and fast forward 10 years, I saw her and followed for another problem. We did a pretty massive correction, and I asked her about her knee, and she said, my knee doesn't hurt at all. And I couldn't believe it because she had bone-on-bone arthritis. And it really began my journey into better understanding this sort of mystery field that we had discarded after it had been pioneered at the Mayo Clinic in 1960. And I think as I've gone on, I've learned a bunch of things about how to make this easier. You know, our objective as physicians is first do no harm. And there's a lot of things that you can do wrong here that can cause harm. But if you follow through this lecture, I think you'll see some really key components on how technically to address some of the problems that scare a lot of surgeons off to make this a relatively easy surgery. In my hands, this is surgery that takes 20 to 30 minutes. I can make my cuts confidently. I don't worry about damaging the artery. I don't worry about the MCL. I don't worry about fracturing the hinge so much because we've got some pearls in here that we're going to address for you that I think will demystify and really make this a pretty simple procedure for you in concept. So we're seeing a resurgence of HTO, and the advances driving the resurgence include an improving body of evidence to differentiate who gets what and to be more accurate about who gets the osteotomy. Knowing how far to correct is really critical. We have improved surgical technology and implants. The move to a medial opening wedge technique where you're not losing limb length. How you manage the MCL also comes into play. Biplanar cuts and hinge protection, all of which we'll address in this talk. So there's been an increase of numbers of HTO in Europe and Asia with a high rate of return to sport and work in young patients. The USA has been slower to readopt despite being a foundational contributor to the original concept. Mark Coventry in 1960 developed a technique for a closing wedge osteotomy that showed some good early success, but then in the 70s was buried under the weight of innovation around total knee arthroplasty and sort of became a side note. So when do we do HTO? So isolated medial unicompartmental osteoarthritis, varus 5 degrees or greater, and yes, even if asymptomatic patellofemoral disease is present. If they have significant and symptomatic patellofemoral disease, that's a contraindication, but the presence of some osteoarthritic change in the patellofemoral joint is not a contraindication in my practice. So how far is too far? So this diagram describes for you the Fujisawa point, which is traditionally where we would historically transfer the weight to with the osteotomy. That was our goal, to get it to 62.5%. But this may be too much. It can impair cosmesis. People say, oh, my leg feels like a kickstand. They have to relearn to walk. And it can overload the lateral compartment. You know, obviously, we want to shift the weight over to the compartment that's healthy, but you don't want to go too far because it can cause damage to the cartilage if imbalanced. So our goal is 52 to 55% lateral, and excellent clinical outcomes with a valgus correction of 0 to 2 degrees have been shown in the literature. So when we talk about osteotomy planning, I don't want to belabor this. Kristian did a really nice job describing this to you earlier, but just wanted to mention Dror Paley is another of the pioneers of American osteotomy that people mention throughout the world. Really the father of preoperative planning and defined norms for various mechanical axes about the hip, knee, and ankle that serve as the standard today for planning knee realignment procedures. I just want you to remember some basics here. The normal mechanical axis is 1 millimeter medial to the knee joint midline, which is about 1.5 degrees varus. And this is really at the cornerstone, one of the cornerstones of planning for HTO, specifically for medial unicompartmental osteoarthritis. Not all varus deformity, however, should be corrected in the tibia. You want to correct what's abnormal. And so we'll briefly just review MMPTA, MLDFA, and the CORA, just so you guys understand what that's about again. So the MMPTA refers to the mechanical medial proximal tibial axis. It often correlates to the mechanical axis of the tibia, and it's a guide for degree of correction in the proximal tibia. So normal is 87.5 degrees, but the range of normal is 85 to 90 degrees. So when you're making your planning correction, you have a little bit of wiggle room here to get it right. The biggest thing you want to avoid is abnormal joint line obliquity. You want the joint line to be relatively flat, and if you correct in the wrong bone, you might have a straight limb, but you may have such an imbalance that it becomes a disaster and the patients know better than they were before surgery. The MLDFA refers to the mechanical lateral distal femoral axis. It helps to determine the degree of deformity in the femur. And so if they have femoral deformity, then you want to address your osteotomy in the femur. Most of the patients that I see that have degenerative medial compartment osteoarthritis have their deformity in the tibia, but it's important to evaluate this preoperatively. And then the other thing, just briefly mention the cora, which refers to the center angle of rotation, center of rotation angle. If you have a malunion of a fracture and the deformities in the diaphysis, and you just correct at the joint line, you're going to fail. So it's important to understand where the deformity lies as you're planning for your surgery. So medial opening wedge HTO has really become the gold standard in modern times. There's really a current trend in this direction. Kim's study in 2017 showed superior 10-year survival rates with medial opening wedge HTO versus lateral closing wedge HTO. Van Heerwaarden out of the Netherlands in 2019 in OJSM showed that 95% of medial opening wedge patients were able to return to work, and 9 of 10 returned within 6 months. So pretty powerful information to help in support of using this technique. And now we're going to talk about managing the MCL. So we want to relinquish the fear of releasing the MCL. So we make a small incision along the posterior border of the MCL. We clear off the posterior tibia and extend the retractor all the way to the fibular head. We release the MCL and then place a second retractor to allow the osteotomy to be made. So we have a short video here. That's going to help protect the arm. Just feel the bone in the back. Once we do this, we're ready to cut. So that was a little treatise on how you manage the MCL, and it really helps to protect you from making a cut near the artery. With an aberrant popliteal artery, sometimes it's within millimeters of the posterior aspect of the tibia. And so by scraping and really getting across there with the retractor, you can cut with impunity, and it really makes it feel safer and actually is much safer for the patient. So next, we're going to move on to the benefits of a biplanar HTO. When we discuss a biplanar HTO, it's not a biplanar correction, but it's a biplanar cut. So we're making 2 cuts. We're making a cut in the coronal plane first, and then a cut in the axial plane. And by doing that, you separate the osteotomy from the extensor mechanism. And that provides a couple of different advantages. So Pape in 2010 and 2013 did a couple of elegant cadaver studies where he showed that you get increased stability when you perform a biplanar cut. So you get increased rotational and translational stability of the osteotomy. And secondly, in his 2013 study and follow-up, what he found was that there's a smaller wedge volume. You're preserving more of the anatomic bone, and you have a larger bony contact area for healing. So if you were to get an infection, for example, that little lip anteriorly, if it heals, then and you can come back, you can remove the hardware, you can place a wedge of bone in the osteotomy site or keep the bone that you have in there, and you have a more stable construct than if you do a simple uniplanar HTO. So I no longer do uniplanar HTOs. All of my HTOs are biplanar, and it's been a game changer. So then we talk about lateral hinge fractures, also a significant problem that you want to avoid. It can lead to failure of the construct, prolonged healing, loss of correction, and in some cases, osteoarthritis. So here you can see a patient who fractured, this is a Takeuchi 3 fracture, and we'll talk about the Takeuchi classification that goes into the joint that required fixation in addition to the standard HTO fixation. So Takeuchi described 3 types of fractures. Type 1 is ubiquitous. It's where it exits directly out the lateral cortex. Type 2 and 3, increased stresses in the plate and bone. And in the type 2s, in his study in 2012, he found a rate of delayed bone union of 40%. And so what happens is in the type 2s, what's so difficult about it, if you look, that's the one in the middle on the bottom. And what the problem is that you lose this inherent stability conferred by the proximal tibiofibular joint. And so now that becomes more free floating laterally, the tibia becomes more free floating, and the excess motion and stress on the plate leads to failure. So you really want to try to avoid this. And the type 3s are problematic because they enter into the joint. And so if they're not fixed, if you don't provide supplemental fixation and you develop a step off, it increases the risk of arthritis in that lateral compartment, where you really rely on that compartment to be healthy with good cartilage in order to succeed. So Nakamura did a study where he actually showed the ideal site for your osteotomy, where you want to end your osteotomy. So above and medial, above and lateral, within the patellofemoral joint, and medial within the patellofemoral joint and lateral. And what they found was that when you're in this WL portion right here, that was the lowest incidence of problematic fractures. There were no type 2 and type 3 fractures. And so this is our goal, is to be just kind of, you want to end the osteotomy within a centimeter of that lateral cortex in that WL portion. So Mathieu Olivier has done a number of really nice studies to talk to us about how to protect the hinge. A hinge wire protects it from fracture. Clinically, with the use of a hinge wire, there was a 30% incidence of fracture out of 206 patients. 72% of those fractures were without wires. So when they used the wires, it significantly reduced the risk of lateral hinge fracture. In the lab, it showed that a lateral hinge wire allowed you to open the osteotomy site 20 degrees versus only 7.5 degrees if you didn't use a wire. And so the failure, it gave you a lot more flexibility in how far you could open it before you fractured the hinge. So there was an 880% increase, 880% greater load to failure with the use of a hinge wire. And so I use hinge wires in all of my osteotomies now. He also corroborated this finite element analysis study where compression and torsion, we get a significant decrease in the stress of the lateral hinge when you used a hinge screw on compression and torsion. So we did a study that was published in Arthroscopy in 2025, where we evaluated the biomechanical effect of a lateral hinge screw on preventing fracture of the lateral tibial cortex after biplanar medial opening wedge HTO. And here we go. There's our hinge screw. We had 12 specimens, and what we found was that the load to failure was 30% higher in the medial opening wedge HTO when using a hinge screw versus controls. This was statistically significant. And so what this allows you to do postoperatively is to allow the patient to weight bear. You can sleep easier at night as their treating surgeon, knowing that you've done something that's going to create a solid construct. So putting it all together, here we are. I use a single pin as a guide for where I'm going to make my osteotomy. It's in that WL section that I showed you before. Once we've done that, then we put in our hinge wire. This is just posterior to Gertie's tubercle, right on that tibial plateau surface laterally. And the next thing is to make our biplanar cut. So I'm making a biplanar cut right behind the patellar tendon. And then once I've made my biplanar cut, I get my wire out of the way. And here we're making our definitive osteotomy cut. You can see we're nicely protected with the two retractors there on the bottom of your screen, the black retractors. Try to go all the way across. And the hinge wire not only protects from fracture, but it also prevents us from over-penetrating with the saw and with our osteotomes. And here, once I've completed the cut, now I'm going to use my wedges. I'm going to sequentially get up to our target opening. Take a picture here on your mini C-arm. That's exactly what I want to see. And now we're going to go to our final wedge height. And we confirm that. You can see we haven't fractured. And then here we're putting on our plate. And almost done. Going to fill the holes. And we've got a nice little system here with a combination of locking and non-locking screws. The plate sits just anterior to the wedge, so we don't have to remove the wedge at any time. It doesn't get in the way. And then finally, we're replacing our hinge screw after we've completed the rest of the osteotomy. And this is a headless compression screw burying it so it's not on the articular surface. And that's it. That's the procedure. So hopefully this helps you sort of demystify this procedure. And as you think about using this in your practice, these are some really important tips that will help prevent problems, prevent complications, and allow you to become very facile in performing this osteotomy technique. Thank you for your time. And now we'll be moving on to cases. So we can begin. So Dr. Wilson, Dr. Kley, thank you for your earlier presentations. We're now going to take the time to go through some cases. I think it's great to do the didactics, but the cases will really bring everything together. And we will bring some principles, maybe some advanced principles here that we didn't fully cover, but I think it will certainly capture the essence of what we're looking at and hopefully be a building block for the folks who are listening to be able to apply these things ultimately to their practice. So here's the first case coming up. It's a 52-year-old man with osteoarthritis of the right knee, presented to the office in 2022. He had isolated medial knee pain and no prior treatment. These were the standing x-rays we had in the office here. And immediately my concern was that obviously significant arthritis, but the lateral compartment was not painful. And what are your thoughts just looking at these x-rays at a glance?
Yeah, so these, Kristian, I'll go first. So thanks, Wimmy. Thanks so much for inviting us as well. Obviously, we're great friends and we do a lot of teaching together. And this is really an amazing invitation for me and Kristian to be part of the core webinars. So this is a typical case, isn't it? 52, grade 4 arthritis. He's an active chap, I'm assuming, and he's come to you in pain with activities of daily living. And so the question is, how do you treat this? There's the escalator of injections, there's fancy new treatments, and then the surgery. And the surgery is going to, obviously, we keep away from total knee here, but we have osteotomy, we have partial knee replacement. Both are great if he warrants it from a surgical perspective. And he's tried the conservative stuff, and we're assuming that we're at the point where we need to operate. So the first thing we do is once we've decided he warrants some sort of surgical intervention, is do some planning. So we need to see, does he have a kink in the metaphysis of the distal femur proximal tibia? Where is his weight-bearing line? So we need proper weight-bearing x-rays, hip to ankle, patella forward, 1/3 of the fibular head exposed. Kristian's got a beautiful hand-drawn picture that he's promised that I can put on my wall at some time to demonstrate how we should take these x-rays. So if we got those, Wimmy?
We do. And before we jump to that, just a quick question. How do you counsel patients that have Kellgren-Lawrence grade 3 and 4 arthritis? You'll see some doctors say, hey, that's a contraindication of doing minimally invasive procedures such as an osteotomy. But looking at this x-ray, do you have concerns about whether the person would benefit from knee realignment if they're appropriate candidates?
Well, we've got two nice series to look at. We got your series, Kristian, with Lobo. So you did that combined series many years ago with Philip. It was 3 centers, I believe. And how many percentage-wise in that series were grade 4?
Yeah, well, I can't remember right now how many were grade 4, but we looked at grade 4, and I think it was 25%, I guess, that we treated with. But I don't want to quote wrong figures. But the surprising thing when we kind of sequenced our patients and looked at outer bridge classification and degree of destruction, then we found that in particular the patients with higher degrees of destruction benefited a lot from an osteotomy. And it all comes down to what Adrian just alluded to. It's the analysis and then the planning. So as I did the analysis and the planning part of the lecture, and once again, equally from my side, thanks for having us, Wimmy. It's really a great honor. So as I did this, I have to say, the first thing we have to do is not planning. The first thing we have to do is analysis. So we need more imaging. But obviously, I mean, you place this case image here first as a provocant statement, and obviously is a full thickness defect, and that intuitively brings the orthopedic community to the field of arthroplasty. So this has to be replaced inevitably. There's no doubt needs a joint replacement. And now we can just choose from partial to total to revision arthroplasty. But that's the only part of the armamentarium which is left. And obviously it's just wrong. And nobody knows what happens down the line with this patient, but nobody knows what happens down the line if you choose either a uni or a total. So we have great data that at 52 years of age, and even if our own data set is not sufficient for you, well, then look at the Baylis study from published in 2017 in The Lancet, which is purely epidemiologic. And it's 55,000 patients from the NHS data set, National Joint Registry, pensatory matched, highest criteria of statistics. And it shows you clearly that a male patient at 52 years of age has a likelihood of early revision of almost 40%. I don't know whether this is the right answer. So I like the statement here, Wimmy.
Great. Well, let's take a look. So he returned. We gave him unloader braces at the time. We did physical therapy, non-steroidal anti-inflammatories. I like to give a trial of unloader bracing to see if they respond, and he actually did. He had a significant brace response, but over time, gradually started to wear off. He didn't like wearing the brace, which I hear a lot. He actually had medial knee pain on both sides. And this is what we did. When we did a standing film, this is what we found. So we had a 12-degree varus deformity. His MMPTA was 82.8 degrees, and his MLDFA was 93. So, Adrian, you want to talk about this and what you're thinking?
So the nice thing about alignment is the numbers are quite easy to remember. So the normal range that we try to stick to is 85 to 90 degrees. And we know that the natural inclination of the tibial slope is 2-3 degrees. We know is what human beings should have. So knowing those ranges, we know that the MPTA is out here. So he's got too much varus in his proximal tibia, and we know that his distal femur is also got varus 93. It should be 90. So if we drop that weight-bearing line down from his hip through to his ankle, it's going to be missing virtually. And the minute you see a weight-bearing line from hip to ankle, that's what we tend to do. Wimmy, you've got the pointer, and I don't know if it works in this mode, but if we take the most medial aspect of the tibia and call that 0%, and if we go all the way over to the lateral part of the tibial plateau and we call that 100%, that is...
You see that?
That's how, we see it perfectly. That's how we describe the weight-bearing line. So what we do is we drop from the hip down to the ankle and we see where is this weight-bearing line striking. And in this patient, it's going to be around about 0, maybe 5%. It's going to just touch the medial aspect of the tibia. So with those figures and also with that weight-bearing line, this is basically a good way of saying this is going to be a double-level osteotomy. There's deformity in the femur, there's deformity in the tibia. And again, for those people that are unfamiliar with osteotomy, you think, my God, one osteotomy is a big operation. Doing two at the same sitting, you've been going now, Wimmy, for, a good decade in osteotomy. And you, like us, have got this down to a 45, 55, 1 hour procedure to do 2 osteotomies. And the recovery is very, very similar. And the results, the best published results, are probably a historical paper from the Mayo Clinic for double-level osteotomy. Is still probably the best survivorship at, I think it was 8 years, 99%, 98% survivorship. So this is a double-level osteotomy. This guy's got kinks, or he's got a varus deformity in the distal metaphysis of his femur and the proximal metaphysis of his tibia. And there are really nice software programs now that are out there that allow you to drop these calibrated x-rays in, and you can literally just dot to dot the top of the femur, femoral head, tip of the great trochanter down, middle of the knee, medial distal femur, lateral distal femur. We can plan on the tibia down to the ankle, and then you literally press a button and you get these answers, and then it guides you and tells you, yep, this is someone that we can treat with an osteotomy. It needs to be done in both the femur and the tibia, and we can actually play around with the digital software to actually work out exactly how do we achieve what we want to achieve. And the next question is, where would we correct him to? And over the last 10, 12 years, we've aimed for the middle, basically. We've moved away from the Fujisawa or noise position, which was too much of an overcorrection. So it's now aim for the middle, femur and tibia, double level osteotomy, if we're going down that route.
Yeah, and that's perfectly said, Adrian. And I, my threshold for doing a double level osteotomy is much lower as I've become more comfortable over the years. I think that most surgeons are afraid of doing 2 cuts in the bone, but I almost feel like these patients do better than if you really push the envelope and try to overcorrect the tibia and create an oblique joint line. I mean, I think you want to create that normal joint line, and that's really where you want to be.
You need it like this at the end, and you can't have a straight leg like this.
That's
or
right.
Like this. So yeah,
it's absolutely right. So my focus is correcting the deformity. I do focus a lot on looking at the MMPT and MLDFA. As you mentioned, 87.5 is the normal, but you have a range. You have about 85 to 90, so you have a little degrees to work with. You don't have to correct it exactly to 87.5 in all cases.
Exactly.
So, Kristian, any thoughts before we go on to the next slide here? The 52% is what I correct to. It's that lateral tibial spine.
Yeah, love it.
Works. Yep,
exactly where I.
Sorry, is that where you go to? No.
Yes, that's exactly where I would go to. As Adrian said, everything around like noise, Fujisawa areas is probably not where we would go today, especially with double levels. If it's 52 or 50 or 55, it's probably not so much the decisive point here. It's very much down to the decision making. And obviously, as we now analyze, we go back to our indication criteria. Yes, this patient has a kink. He actually has 2 kinks, and therefore he's a candidate for an osteotomy. Period. It's just like that.
So Nakamura shows us that if we go to more than 14 millimeters of opening, you're more likely to crack that lateral hinge. And so 15-degree correction here is probably on the order of about 18 millimeter correction, which would be pretty massive. And so again, 14 millimeters is sort of my cutoff to go to the double level. And then I obviously also look at the MLDFA and MMPTA to make sure I'm correcting the deformity. In his case, yeah, go ahead.
I like that remark because it's very important to listen to what you've just said. 14 millimeters for you is kind of a tipping point. Well, it might be that you have a patient that needs post-traumatic patient that needs 14 millimeters. Might all be the case. But generally, when you have an opening at the single level of 14 millimeters, think again. Go back to the drawing board. Maybe you're overdoing things as if you were trying. You're standing in front of the dartboard and you have an arrow and you're standing 100 yards away and you try to take this dart and throw it in the middle of the bullseye. It's quite unlikely. Just take half the distance and take 2 darts.
Yeah.
So.
It's a great point. And I think, as I've become more comfortable with it, correcting less in each bone allows you to be more aggressive in physical therapy afterwards. If you correct all in one bone and you've got this precarious situation where it's a big opening and you have a very small volume that's holding everything together, it can be problematic. So this was my planned correction, as you can see, an 11 millimeter correction. And the other point here is that you don't want to just do 1-to-1. You hear some people say, oh, well, 1 degree equals 1 millimeter. You have to measure it. We have technology to be able to calibrate our films and actually figure out how many millimeters will correlate to the degree correction you need. And I think that's critical. As you can see, if I just did an 8 millimeter correction intending to get 8 degrees, I would fall short by 2 to 3 degrees. And that's going to cause you to fail, particularly as the correction size gets bigger. But any comments about the correction degrees, any other points before we move on to the next slide?
Yeah, I mean, there is one diameter of the bone. I think from memory, the diameter, medial lateral diameter of the bone, I think if it's 65 millimeters, then 1-to-1 works. I can't remember the exact figure, Kristian, but there is one diameter where that works. But obviously, people come in different shapes and sizes. The tibia in particular, both bones are not circles. the tibia is triangular, and you hit the medial side quicker at the front than at the back than you do at the front. And so, yeah, you need to do your planning, and it all comes down to deformity analysis.
And obviously, that's all because we are translating angles into metrics. And as we go into metrics and we keep the same angle, then obviously, I don't know, Shakira and Shaquille O'Neal have different dimensions.
You certainly do.
Exactly. That's an illustration that most Americans can understand quite well. So this was what we did. So we did a double level, as you guys pointed out, double level osteotomy, 52% lateral with an 11 millimeter medial opening wedge and an 8 millimeter closing wedge on the femur. I do a hinge screw on all of these folks because I just feel more comfortable allowing them early physical therapy and weight bearing. Particularly in the larger corrections, it's important. But this is something that is kind of the standard construct for my double level osteotomies.
Yeah, that's good with me. So we've got the hinge screws protecting the hinges. We think that's a really nice. We were really, really struggling because the original plates, the Tomofix plate, which was our go-to for many years, had this fantastic technique. As you actually reduce the plate onto the bone, you could actually reduce the hinge if there was an issue, and compress at the hinge indirectly. And Kristian and I were talking about this. The new clip guys came up with this fantastic idea of putting in a K-wire to protect the hinge, and there's lovely data to show that the hinge is protected up to 800% with a wire. So Kristian and myself started messing around with little hinge screws, and I think that looks very nicely protected. Obviously, it's a biplane technique, which has the advantages. So you're not actually by doing a biplane osteotomy, and I'm sure in Wimmie's lecture he would have covered this. But in terms of biplane surgery, it creates this nice surface that creates a stability at the front because you're not going all the way through at the front of the bone. You're protecting it with an ascending biplane on the tibia and an ascending biplane on the femur. We can just make those out. So yeah, it looks great. It's very good.
So I do biplanar cuts on everybody. I absolutely agree, Adrian. You're the one who brought this to my attention, and not only does it increase the stability, but it gives it a surface area to heal. So if for some reason you get an infection and you have to take the plate out, it's a stable construct. If you have to take a plate out at 6 weeks or 8 weeks, just imagine when we were doing monoplanar cuts, you're relying on that little tiny volume laterally or at the hinge to hold everything together. But now you have that surface between the extensor mechanism and the body of the proximal aspect of your osteotomy on the tibia or the distal aspect on the femur that's now healed. And so you can just stick a bone wedge in there and have them weight bear as tolerating immediately. So that's another advantage for that.
Yeah. And for the trainees, this was, when I first started out, I used to think, my God, this is scary surgery. I remember the first opening wedge HTO that I did, I was, in 2005, 2006, when I started with this technique, I had to learn it. And I remember thinking about the biplane, and worrying about it. But actually, you do the courses, you do them on cadavers, you watch the lectures, go and do a course, do it on cadavers, go and visit Wimmie, come and visit us if necessary, see it, and then do it. And actually, it's very straightforward. And what was it in your unit, Kristian? It was the trainees were doing the HTOs, and they actually
it's a nice little anecdotal thing because Philip Leuvenhofer, obviously one of the forefathers of this technique and a true mentor, he ran that unit where I started as a registrar, and he came across that crazy idea to actually allow this surgery to be a first hand-on surgery for the registrars. So actually no implant removals, but HTOs. And obviously all the consultants in the unit just went completely bananas and said, that's probably the worst idea that you've ever come up with. And he said, okay, well, if you think so, then let's just try it and collect our statistics. And so they did. And obviously after a certain period of time, they looked at their data and they found that in terms of all measured values, the registrars scored the consultants easily, just because they were probably better prepared, more particulars in preparation, and so on and so on. So this is and that is actually one of the great achievements from Leuvenhofer. This is a very structured surgery. It follows a path. And if you follow this like you're building an IKEA shelf, you cannot go wrong, unless IKEA once again forgot a screw. Yeah, but obviously this is a very structured thing, very schematic, no way to fail.
It's funny you mentioned that, because the fellows come to me and they've come from other institutions, and they see we'll have 5 or 6 osteotomies on the schedule, and they'll say, isn't each one of those a 2-hour surgery? And I say, no, this is about a 20-minute surgery. And they say, that's not possible. But, with the tips and tricks, the proper planning, and everything else that we've done, you see that. So that's a great point that you bring up, Kristian, because it demystifying and taking the fear out of this, as we did with your planning lecture, going through the history of everything we've done, and then looking at tips and tricks. The fellows often come to me for the first time, and they see 5 or 6 osteotomies on the schedule. They say, well, we don't have time in the day. It takes about 2 hours to do that each surgery. I said, no, it takes about 20 minutes. And if you follow these things, you're not rushing. It's no wasted motion. You're not taking 17 fluoroscopic films to see what's going on. Once you protect the artery, you protect the hinge, you go. It's a simple cut, a couple of knocks, and you're done. So I think that's what's really exciting about this. This is, I think Adrian pointed out earlier, this is a 45-minute to 90-minute surgery. The incisions aren't massive, and the morbidity is much less than it would have been, say, 20 years ago, when we were sort of messing around with archaic concepts. Point to the knee that we fixed. So here he is, 11 weeks out.
Okay, and happy candidate for the contralateral as well.
Exactly.
Wow, he needs to get the other one done, doesn't he?
Yeah. Well, the funny thing that you see here is obviously he's offloaded on the medial side, so the result is great. But what you can see that he's now struggling due to the relative limb length shortening on the left hand side, because he's still in a bow.
Yeah. Well, what's fascinating about this is that, first of all, that was the side that looks deformed was the better of the two sides, which it's hard to believe after you see the leg straight.
Yeah,
second
obviously.
Of all, he has absolutely no pain in that other side now. He had pain in both knees, and initially wanted to plan. You almost have to convince these people to get the other side done. They feel so much better after you fix this. Sometimes that they don't come back for a while. I just had a lady yesterday that we did 3 years ago, and we just did her other side because it was just starting to hurt, even though both hurt initially. So it's very interesting to observe this and see these results.
Yeah.
So here he is, 4 months out. This is a guy who couldn't even get up out of the chair, was going to have to quit his job.
I mentioned this in my lecture, but, it really is weird that, Wiemi, you cover everything, and Kristian has seen everything as well. And, we've tried the meniscal transplants, the complex cartilage surgery. We've done the patellofemoral stuff. We've done the complex ligament stuff. We've got the partial knees, total knees. We've got all of these different things that we can do. But hands down, the best results you can get in knee surgery is osteotomy. It's amazing. And it's, obviously you went into this. When did you really first start getting going? Was it 4 years ago when you really started to ramp it up?
Really about 4 years ago. Yeah.
Yep. And now you've got one of the highest volume practices probably globally, because you often have 12 in a week, which is just ridiculous. And it is really interesting that in North America right now, very few people are doing osteotomy in a way such as yourself, where they're doing high volumes. It's still a very rare operation, I believe. And what's interesting in the UK and again it's in Europe is this has just exploded. And if you're interested in knee surgery, this is an operation that you need to learn how to do. That's brilliant, Wimmy.
But first, a hand kudos, Wimmy, as we see the Mikulic line now on the operated knee. I would say the result is spot on.
Perfect, buddy.
Thank you. Yeah, I just try to get just past that neutral line, and I got this guy from you guys, and it's just fascinating. It's hard to wrap your hands around the fact that you're not taking away the arthritis, but the pain goes away. But the pain does go away. I mean, I think you guys can echo these comments, but it's fascinating how the patient comes in and they don't understand. I say, why is it that my knee pain's gone away? Because the space between the bones hasn't changed.
Well, here's the point. Let me just interrupt here, because there is a nomenclature thing, as you said, as you don't take away the arthritis. And I think you take away the arthritis. You don't take away the wear and tear. And in the American medical English, that would be osteoarthritis, obviously. But the inflammation, which is described by the suffix itis, is actually dealt with. So that's exactly what you're doing. So you can proudly say you have taken away the arthritis, but you couldn't fight the wear and tear.
That's perfect. And I, it's interesting. I explain that exactly to my patients when they're not sure if they want to embark on this journey. And I say the arthritis takes two things. It takes the degenerative joint disease, and it takes your body to notice it. And what we're doing is we're taking away your body's recognition that there's a degenerative change. And we often get x-rays like this. We get a flat plate and we capture both knees, and we're treating one knee and the other knee looks worse. And I say, what about the other knee? Does that bother you? I say, no, that's my good knee. And I think, should I tell them? Maybe I shouldn't say anything and tell them that the other knee looks worse. But the point is, we don't treat the x-ray, we treat the person. And that's such a great point, Kristian. Such a great point about it. Arthritis is different than degenerative change.
And also just to come in, the likelihood of this being good at 10 years is extremely high. So, again, it's in my lecture, but, our HTO series, which is 651, we have 92 in the DFO series, and we have 10-year data. And, it's a 92% survivorship type procedure at 10 years. And Ronald's got some anecdotal but lovely results from 20 years of working with René Mate. This is not going to buy this guy a year or two. This is highly likely to be still functioning well beyond 10 years. And there's plenty of papers to back that up.
Well, and everything we just set aside, if this becomes common standard and common knowledge, and obviously is the treatment of first choice, I want to see the orthopedic joint arthroplasty surgeon, and I'm myself one. I want to see the arthroplasty surgeon who would actually opt for a total knee for himself in that same situation.
Yeah, just to jump in there. So we do 1,000 joint replacements a year in our combined practice. Admittedly, 700 are hips, but we do 300 knees, 100 partials, 200 totals. So we are firm believers in joint replacement surgery. But this is our go-to, not on biological, as chronological age, but on biological age, activity levels, and on this presence of a metaphyseal varus on the planning. So, one of the interesting things that has come to note recently is this original Isakos recommendations for osteotomy from 2002, from an Isakos, it was a 50-year-old, 40 to 50-year-old male with a BMI of less than 30, non-smoker, with less than 10 degrees of fixed varus, with less than 10 degrees of fixed flexion. That was your go-to osteotomy. Those were the indications. And now, if you look at the consensus documents that have come out of the UK and much more importantly, the big ESCA consensus document, age goes out the window. Because, Takeuchi's got a study looking at under and over 70s in Japan, and actually the over 70s did better. It all comes down to the planning and the biology of the patient. And this is an operation that can work in young people for osteochondral defects and for offloading meniscus. And of course, the workhorse here is for the arthritis patient, and that could be 40, 50, 60, depending on what I've just talked about. So, yeah, great case.
Yeah. And age and BMI, I mean, some of my happiest patients are patients that had elevated BMI. They were told they were too big for a knee replacement. They had unicompartmental arthritis, and they were suffering because they're 40-something years old. And they say, well, I've got to wait 10 years and I've got to lose 150 pounds. Well, we did the osteotomy And one woman lost 50 pounds afterwards because she was finally able to work out. She had no pain in her knee. So, I think there's a lot of the old teachings we're learning with newer technology and new refined techniques, better understanding of the anatomy, how far to correct, things like that, that maybe some of the old contraindications melt away.
Absolutely.
So case 2, we'll move to case 2. This is a 50-year-old woman. She's had long-standing lateral knee pain. She has no medial or patellofemoral pain. Pain when seated for long periods, limited walking tolerance. This is an atraumatic insidious onset of pain. She was about 400 pounds and lost a bunch of weight, and says she's been walking funny for a long time. So here we go. So here she is in my office. So you see this massive valgus deformity. She responded well to lateral and loader bracing. She has no clinical patellofemoral disease in the office. And this is what we're looking at. So total knee for this, unicompartmental knee, osteotomy. What are you guys thinking?
Well,
Yeah, well, yeah, I mean, looking at that, how old was she?
She's 50 years old.
50s, yeah. So once again, it is somewhat a similar scenario, just the other way around. So we are not having a massive varus deformity, but a massive valgus deformity to an extent that obviously makes these people have a funny gait, because the knees would actually buckle against each other at each step. So they try to compensate, and that looks wobbly. And once again, as Adrian said, the principle here, detect that there is a malalignment, Mikulicz line. Second thing, analysis. So let's analyze where the deformity is. And if there is a deformity in the long bones, and I assume here is at 2 levels, it's probably a double level osteotomy. As the rule of thumb, once again, applies, Mikulicz line not touching the knee anymore is highly likely that it's a double level. That counts now for the left side. The right side might be a single level. We will see.
So that it's interesting. So that you brought up the article earlier about, patients under the age of 54 in 2017, a large epidemiologic study. And one of the biggest problems is the rate of revision, and often these folks under the age of 54 will get a total knee, and then you have to revise it in 4 years, which is not a good thing, because a second total knee is not as good as the first. And a lot of these patients are not happy. And it was recommended to her that she had a total knee, but I thought this is a perfect patient for a double level osteotomy. So here's our planning again. Interestingly, she has a little bit of a deformity on the other side, not so bad, but look at this massive deformity here. So if we look at the actual numbers, she has a 99-degree MMPTA and an 80-degree MLDFA. So we planned a 10-degree correction in each to bring her to neutral, slightly varus, 12.7 millimeter medial closing wedge, and a 13 millimeter medial closing wedge, distal femoral osteotomy. Or is there? So, Kristian, I'm going to have you talk about FACTAM to the group, because I learned this from you.
Yeah, FACTAM is actually an acronym which was brought up by Mathieu and me. So when I treat the femur, in 99%, you should never say never. So some post-traumatic cases I open, but for the regular frontal plane deformities, I close my femora, because the femur is the more brittle bone here, and it's actually inherently more stable if you close them. So femur always closing, and obviously you can address then varus or valgus deformity either from the medial or lateral side. And the tibia, I hate to go to the lateral side. I do that for rotational osteotomies, but for standard frontal planes, I just go to the medial side. And there you then have the chance to either open or close the osteotomy to correct varus or valgus deformity. And femur always closed, tibia always medial, makes up FACTAM.
Yeah, and it's funny because in the United States, we're classically trained to do a lateral opening wedge distal femoral osteotomy, and I've completely abandoned that since working with you guys, and it really makes a lot of sense. I mean, I've seen a bunch of patients that have come to me who'd had previous distal femoral osteotomies, big corrections, and they have a tight iliotibial band and they can't flex their knee, and they're absolutely miserable. And you just don't see that when you do it on the medial side. Plus, you get that extra bony contact. It's just a more civilized surgery. So I think that's a really important point.
All the difference is in primary and secondary bone healing.
Yeah.
So if you are able to compress, then effectively this surgery will start to heal in a week after surgery. It will probably be stable after 3 weeks. If you really compress a closed wedge osteotomy and you manage far under a millimeter, then you have primary bone healing.
That's right. So here's the operative plan. Evaluation. I always do an arthroscopic evaluation, clean it up just to decrease inflammation. And every once in a while, you'll encounter somebody where it doesn't look like on x-ray that they've got that much disease on the opposite compartment where you're transferring stress. But every once in a while, you'll find someone who does, and you have to abort. So I always do an arthroscopy when I do these surgeries.
Hey, an interesting thing that Wimmy is a really lovely paper that came out of the Fowler Institute. And I remember one of the early osteotomy courses in Basingstoke, when I was running them, it was presented not by Al Getgood, but by his predecessor who ran the unit before. And that's terrible, I've forgotten his name. And it is a lovely paper that showed, actually, I think it was Fowler himself, that looked at people with terrible medial compartments, and they had some disease in the lateral compartment. All their symptoms were medial. There was a medial pain, medial issue, but they weren't perfect in the lateral compartment. And they just ignored it. And rather than overcorrecting these patients to a noise position, they actually put those patients into the middle, and they got good results. So I used to do, because I was taught by Peter Myers to put the telescope in, tidy up, and I was really convinced by my German colleagues who were doing very, very high volumes in Germany, way beyond me, in the kind of early part of my career with this. Kristian and Leuvenhofer said to me, just don't do the arthroscopy. And it was really went against my what I wanted to do, because I wanted to get in there. It made sense to, tidy up a meniscal flap or whatever. If they have mechanical symptoms and there is a piece of something floating around, a loose body or a flap of meniscus, of course we do the arthroscopy.
Mm-hmm.
We've completely abandoned arthroscopy now with our osteotomy surgery. We tend to take the hardware out when they've healed. And if they have ongoing symptoms and we haven't got there, we might put the telescope in at that point. And since I did that, I actually found that the patients did better, because there is a hit from the arthroscopic surgery that we slightly underestimate. And there was good studies coming out of Germany, arthroscopy plus osteotomy or just osteotomy. And so I moved away from it. Comments from you, Kristian?
Yeah, well, it was our own learning curve, I would say. So we scoped everyone because we actually believed in the arthroscopic pump to deliver some water for cooling of the osteotomy and the saw blade. But that was when the osteotomy itself was rather 70 minutes. So now we don't cool the blade anymore. We're just quick enough to not apply any heat.
Yeah, that's great. And I think for the residents, I think early on, looking at the cartilage surfaces, I think as an academic experience, I think it's important. It kind of gives you it gives you an idea. But I do think that you have to pay attention to what the results show clinically, and there is evidence, as you point out, that you might not need this. You might not need this. For me personally, I've only had to abort in 2 or 3 cases where they had grade 4 changes, where it didn't look like they had it, and it concerned me. I've also had a couple of failures where we've done the osteotomy and everything went well, and then the other compartment degenerated. So the question is, are there some folks that maybe we haven't identified yet that will not be good candidates?
Yeah, there's a good call for a cartilage mapping MRI scan, for example. Can we assess the quality of the contralateral cartilage? That would be great. So everyone who's actually now taking this course, sitting it, and actually is a young registrar, make up your mind, guys. Feel invited. Feel welcome in the family of osteotomy guys, and just do some research. Help us. We are not there yet.
Solve the problem. That's right. Still learning. So this is the what we did. So the normal appearing tibio-femoral compartment. medially, which was encouraging. She had ICR grade 3A degenerative changes in the central fifth of the femoral groove, and ICR grade 4 degenerative changes over 80% of the lateral tibial plateau and 40% of the lateral femoral condyle. So the patellofemoral changes I ignore in general, particularly if they're asymptomatic. If I didn't do these surgeries in patients who had patellofemoral disease, it would reduce the volume of surgery by about 70%. And the outcomes have been phenomenal when they have isolated symptoms in that joint and you correct them as planned.
Yeah.
So here's the medial closing wedge HCO, medial closing wedge DFO, and this is her postoperative foams. So we brought her into a touch of varus. What about your postoperative protocol for these folks? What do you guys do for a correction this large?
Well, for me, I always used to take them 4 weeks, 10 kg weight bearing, no brace, and then let them go over a 2-week period to full weight bearing. But actually, since we started working together, Kristian elbows me out of the way, and he's completely de-skilled me because he's so much better at the surgery than me, and he's so accurate with his saw cuts that he lets them go fully weight bearing from day one. But we encourage all these patients to basically do as little as possible for the first 2 weeks, leg in the air, gentle return of range of motion, get the quadriceps firing, think about a complex. ICE is really important. We use a thing called PhysioLab, which we think is a step up from Game Ready. But these, ICE and compression devices are absolutely, really, they make such a massive difference, because what you want in these surgeries is as little swelling as possible, because it's the swelling that drives the pain. So accurate surgery, respect the soft tissues, hold them nicely with these internal fixators. Think about a hinge screw. Use a bone wedge in the opening cases to fill voids, so that you have this cork in a bottle idea. And for these closing wedge osteotomies, get your cuts accurate, get good bone-on-bone apposition, use the compression element of these plates that allows you to physically compress the osteotomy sites, and they do very well.
And I like your remark here, physiotherapy 4 weeks post-op. And I love that, because it's patients and colleagues constantly drag you into kind of a rehab mode where you think you should and have to accelerate things here. But what we have here is a controlled fracture, an iatrogene fracture. And I would be that crazy in a fractured elbow that is treated in a cast or a plaster of Paris to actually send the patient to a physiotherapist. I mean, nobody would do that. And we have a plaster of Paris here, but it's actually mounted to the bone. So,
yeah.
And oftentimes they're going to physical therapists that may or may not, they're outside of where we live. They may not be working with us immediately. And what you don't want to have them do is be too aggressive in a controlled fracture.
One of the things that we learned really from the Netherlands, from Ronald, they're all obviously biking everywhere over there, is we do keep them off push bikes. So we don't allow people or encourage people to start turning a bike for probably 8 weeks, because we really want the femur to heal up nicely before the patients start to actually put big forces through the osteotomy. So for us, it's, he does literally let them there was no brace. I don't think that's helpful. And it's a very quiet couple of weeks. It's the ice and compression and wake up the quads. And actually, these patients are surprisingly comfortable. You'd think after such a surgery, they would be climbing the wall. And historically, osteotomy surgery used to be regarded as the most painful thing you could do to a patient. And a lot of the time that was because of the mini compartment syndrome that you gave them with your HTO. When you cut the bone, you didn't respect the vessels, particularly the aberrant branch of the popliteal vessel, which often I think got clobbered close to the bone. They bled, they had swelling afterwards, and it was just a nightmare for the patients in terms of pain management. I think by respecting the anatomy and following the steps that are now laid out for you, as Kristian said, these patients are comfortable, they have a quiet month, and then they get going.
Yeah, I like to use a brace just because with the newer techniques, sometimes they have no pain. And I'm afraid that if they don't, they'll just start walking on it and say, hey, I feel great. And the particular femur, which is not as stable an inherent construct, you can have loosening, you can develop a non-union, a malunion, you can have a fall. So I like to use the brace more to just remind them that they've got to be careful and that they have, as Kristian pointed out, a controlled fracture.
Yeah, fully agreed. And action. Great, Wimmy.
So you see it's straight now.
Yeah.
And she hasn't fired those hip abductors for about 20 years.
Yeah,
So
and
now that you've straightened her out, she's got to
to her
balance her
gait.
pelvis. Yeah, it's wild. And some people say, well, it's the leg length, but it's not so much the leg length. I don't think. I think it's more that she just hasn't had to stabilize her pelvis because her legs have been pointed in.
One of the things that people worry about is a change in leg length. Now, when the leg is so bent, the actual distance from A to B is X, but in fact, their leg is longer. But because they're bent, they have a relative shortening. And when you straighten up these patients and you correct the kink, okay, you've removed some bone, so you have shortened them, but actually it kind of all works out. In a case like this, she would be between 3 and 7 millimeters shorter as a result of those two massive corrections, because she would have had such a bent knee to start off with. Just something.
It's a much more subtle leg length correction, as you point out, than people think. And I think there's more of just gait retraining from having the limb reoriented in space and having to refire different muscles, learn to educate different muscles.
Yeah, that is definitely great. Okay, that's 1 year. She lost some more weight.
Yeah, she did.
See.
What's really interesting with me is all the return to sport and activity papers that have been written now. And if you get into this as a trainee and you think, what can you do after this? There's been a very significant focus on return to activity. And actually, it's remarkable what people are able to do. A lot of the work and a lot of the research has come from Europe. So there's lots of people getting back to alpine sports and walking. If close to the osteotomy, you were able to compete and run and be active. A lot of these patients are getting back to impact activities at a very high level. So it's a really, really interesting one, return to activity and return to sport after an osteotomy.
I just had a double level come into the office the other day, 6 years out from a double level osteotomy, who was told he needed a total knee. And he's been playing basketball twice a week for the last 6 years, still playing basketball, occasional ache, but no pain. I think, to your point, there is a tremendous benefit in terms of returning to physical activity that you won't necessarily see with a replacement.
Yeah, I have one patient recently. I had one patient who was funny because I fed up with this return to sports thing, and can you treat professional sportsmen and so on. So I had a martial arts guy who came into my office, and he is actually in the Guinness Book of Records for the world's hardest chin, because his funny sport is to kick baseball bats. So he bashes baseball bats in 70 in under a minute. And so he came to me and said, well, I need that leg corrected. And I thought, well, I don't know if that's a great idea to cut the world's hardest chin and probably the femur as well. But so I did. And this crazy guy actually went back in and repeated his record live in German television. So it is where osteotomy may bring you to. I don't know whether it was the plate that actually hardened his chin even further. But this is what patients do. And so return to sports after a fracture is simply like coming back after a fracture. And why shouldn't you? So bone consolidates, it should heal. Now, looking at this lady here that you treated, and I think the result is remarkable because her other side the right side was almost straight. And now it looks as if the right side is valgus. What have you discussed with her? Is she happy?
Well, it's interesting. She's now 3 years out from her initial surgery. And yesterday I did her other side. And her
that was not we haven't discussed
how about
that.
that? We didn't even plan
We
that.
haven't discussed that.
So yeah.
Okay, so we're waiting for the follow-up in 6 months and 1 year.
Yeah, and she had absolutely no pain in either knee for 3 years, and then the valgus increased. So her valgus went up by about 4 degrees over the ensuing 3 years on the opposite side, and so she elected to have that fixed. So,
did it take a lot now to convince her?
not at all. She's been telling all her friends at church, and it's done wonders for the osteotomy business in my office. Well, listen, gentlemen, thank you so much for taking the time. I realize it's a late hour. Gentlemen, thank you so much. Professor Wilson, Professor Kley, thank you so much for taking the time to join us today and help teach our residents on this really burgeoning topic. Obviously, it's exploded in Asia and the UK and Europe, but we're seeing it grow in the United States as well. And lectures like this will only contribute to the popularity of a really important technique. So thank you very much.
Thanks, Wimmy.
Thank you, guys.